So welcome to our WebEx. We are going to have an hour with this great panel. We have Dr. Joshua Sonnet, Dr. Arun Rajan. We have our ITMIG president, Dr. Edith Marome. We also have a pathologist on the call. And what the flow of this is going to be, I'm going to hand it over to Dr. Rajan, who is going to start with a PowerPoint presentation. And I'm going to start with that. All right, so I will let you start, Dr. Rajan.
Thank you so much, Pam, and I thank ITMIG for the invitation to participate in this webinar. Certainly something new and different given the nature of things these days. But I think hopefully it'll be a very productive discussion. To set the stage for this discussion, we thought we should maybe start with a few basic slides depicting the basics of thymic cancer biology and treatment guidelines. So as you all know, thymic epithelial tumors, as the name suggests, arise from the thymus gland, which is located in the center of the chest, also known as the mediastinum, to be more precise, the anterior mediastinum. As you can see in the figure, it is the gland is surrounded by critical structures, the heart beneath it and behind it, the lungs on either side, the great vessels arising from the heart, which are in close proximity to the gland. And these have important implications, especially from the surgical perspective. If we move on to the next slide, the radiological appearance of these tumors, as is visible on a CAT scan, is illustrated. Pam, I think you may have to click on the next button. So that is the picture that we typically see at least for early stage disease. You have a well demarcated mass. It is sitting in proximity to the vessels, as you can see, which are highlighted by contrast and appear white in that image. Moving on to the next slide. So the first few things we need to do when we make a diagnosis before we come up with a plan is to define the subtype of the tumor, as many of you know, and the extent of spread of the disease. So to define the spread of the tumor, to define the characteristics of the tumor, you do need microscopic evaluation. And Pam, if you could just go back to the previous slide. You can get tissue either from a biopsy or from surgical resection. Pam, can we just go back one slide?
This
previous slide.
I love it. If there's the questions, I would like to ask my doctor.
That's okay. We can just move on. So yeah, exactly. This slide, as you can see, the images on the left side show you the fact that the tumors can look quite different under the microscope, and that has a lot of implications. And that's how we subdivide these tumors. A lot of time we are asked about mutational profiling and the significance. I would say for this particular tumor type, the mutational load is very low, as is indicated by the disease demarcated here on the left side. And the absence of mutations or the lack of mutations makes targeted therapy challenging. Moving on to the next slide. The next important thing to know is the extent of disease, and that is what we essentially call staging. So Pam, the next slide, please.
Do you see that?
Actually, one behind this. Can you just go one back? I'm sorry, that's fine. So staging essentially involves the extent of spread of disease. And, we have various systems to define it. And what we typically use nowadays, or what is recommended, is what's known as the TNM classification. So without going into details, it's really the extent of spread of disease, and that has a bearing on management. So moving on, what are the principles of management? What are the basic guidelines, and what modality of treatment do you use in what situation? And move on one more slide, please. So here are the management strategies. It all really depends on the stage of disease. I think we'll have to skip back one slide. Sorry about the technical issues.
There you go.
I have the management strategies.
Okay, I see the next slide, but nevertheless, The management strategies depend on really the stage of disease primarily, also the histology, the subtype of tumor. So as you'll see, depending on the stage, for early stage and locally advanced disease, surgery is really the key to good disease control. And that modality can be aided by chemotherapy or radiation, especially for locally advanced disease or stage 3 disease. Radiation also has a role in the post-operative setting for, in this situation. As far as biological therapies or chemotherapy as the primary modality.
Can you go back? Can we go back to that slide in a second?
This
Yeah.
one?
Sorry, it's beautiful. And just to highlight what Arun said is that you see there's 3 major modalities, and one of the important things that we think is important in as clinicians all across the world is that we all work together. So the surgeon, oncologist, and radiation therapist and your primary care, when who's ever trying to figure this out, the best treatment and the best order of treatment is that your treatment team are all talking to each other and working out together. We're all one big team sorting out what's best for you.
And one can't stress that enough. That is a critically important factor. And as you shall see, in many cases, this triple modality therapy, or at least 2 modalities, might be required. So the fact that folks talk with one another is critically important, as Dr. Sonnet mentioned. Now, for advanced disease or disease which cannot be resected, where it is metastatic, the primary modality of treatment is what we call systemic therapy, and that in old days it used to be essentially chemotherapy, but now you have newer biological treatments also available, and that's used. As you'll see at the bottom, clinical trials can be considered and should be considered, in our opinion, for any stage of disease. Most of the trials focus on advanced or locally advanced disease, so it is a consideration. And you will note that I'm not specifically mentioned immunotherapy, which obviously is of a lot of interest, but many of us believe it should be used in the context of a clinical trial, and we can talk about that later. Moving on to the next slide, this illustrates the various forms of systemic therapy. Pam, if you can move one slide, please. Yeah. So this slide shows you what we use essentially for frontline treatment, and then for treatment which one can use when the disease returns. For frontline therapy, especially you use combination chemotherapy. And for second-line treatment or for recurrent disease at any stage, you can use it for various drugs, usually individually. The ones marked in orange are essentially chemotherapies, and the ones marked in purple are what we consider biological therapies. I've also pointed out, as you'll see, there are some drugs we preferentially use for thymomas because they work much better. Examples are pemetrexed and octreotide. And then there are others which work really for thymic carcinoma and don't really do much in patients with thymoma. And those are sunitinib and lenvatinib, which is very recent. The ones in the middle there, gemcitabine, capecitabine, what drugs called taxanes, as well as the targeted drug everolimus, can really be used for both histologies. So that's a very broad overview of the treatment options and the treatment modalities one could use. Hopefully that provides a background for further discussion. Thank you. And I'll hand it back to you, Pam.
Okay, great. Okay, just a little bit of housekeeping. So if you are not, I thought I had muted everybody, but if you could just make sure that you're muted so we can cut down on the background, except for the panel, of course. What we're going to do, you'll see on your bottom right-hand corner a chat button. Which that will be, well, first I'm going to read some questions to the panel that were already submitted. We have about 15 questions or so that were submitted prior to the WebEx. Then I'm going to open it up to everybody on the call to be able to submit via chat your questions, and I will read them. So I'll start with the first question. And these are just in order of the way they came in. Is there anything we can do to stop a reoccurrence of thymoma? Does removing the thymus make our immune weakened?
Okay, maybe I can start here with an answer. So that this question is important, and it really focuses on what we call the prognostic factors, which determine how good one would do with this disease, and that has a bearing on recurrence of disease as well. And among these factors, there is obviously the subtype of thymoma, the extent of spread, which has a bearing. But one of the most important factors is the completeness of surgical resection, which has a tremendous bearing on the risk of recurrence. I'll request Dr. Sonnet to expand on that. But before I do so, I'll just say, in terms of removing the thymus, if in general, if the thymus is removed in adults, it really should not have a big impact on the immune system in subsequent years. However, it's a different story if the operation is done in neonates and in very young children, because that's when the thymus is really active. There have been some studies which have looked at patients with myasthenia gravis to see if immunity changed after removal of the thymus. And there was an increased incidence of certain autoimmune diseases, but bear in mind, these patients had myasthenia. So this is an old study, but it indicates that it was really to do with the constitution of the patient, the immune system, rather than removal of the thymus. Josh?
Yeah, so I mean, the thymus is almost mythical in nature, but the thymus really works hard at birth and is really big and is crucial to the development of all our immune systems. And between birth and 20 years, pretty much, the thymus slowly starts not functioning, especially in the teenage years. And by age 20, pretty much your thymus is doing very little, and it stopped the development stage, but it does have some activity. And absolutely by age 40, it's basically should not be active. And most of the diseases we see associated with thymoma or with the thymus, myasthenia gravis, and a whole host of other autoimmune disease are almost a factor that this thymus should not have been there, and now it's causing more trouble than it is in place. So what Arun referred to is that, some of the patients that had their thymus taken out at autoimmune diseases, that almost assuredly is related to a malfunction of that thymus rather than taking out the thymus. So although we are not always right in medicine, as far as we know right now as a collective field, taking out your thymus as an adult has no real effect on your immunity, because the function of your immune system is now developed, and it's all through your system. In terms of what can we do to prevent a recurrence of thymoma, again, as Arun said, the treatment of the thymoma in the beginning, particularly how you biopsy it, if it needs biopsying, is important, and also the surgical resection, that it's complete. And sometimes you can have a complete surgical resection and the tumor was of such a nature that it was already spreading, kind of like breaking out of the capsule. So even with a perfect surgical resection, you can still have recurrence through no fault of the patient, through no fault of the surgeon. What can we do, or you do as a patient, to decrease recurrence? I don't think we have any magic bullets or have anything like any one medicine or any one lifestyle. I think we all agree that a healthy, balanced diet and strong immune system per se is important, but I don't think there's any one thing you can do to decrease that other than staying healthy, keeping yourself in good shape. If any of the other participants want to chime in, welcome to make that a roundtable.
I think what we'll do is we'll just continue to move along. We have a lot of questions. So the next one is a couple part question. What is a prognosis in stage 1 type AB thymoma? And how long have you had thymoma? How long has it been growing in the chest to receive a 7 centimeter diameter in size?
So I would say the prognosis for stage 1 disease in general is excellent. Patients do very well. Most patients do very, very well with complete surgical resection. Type AB thymoma, it's one of those histologies which is associated with an excellent long-term prognosis if the disease is caught early and it is removed surgically, removed completely. So the short answer is it is associated with an excellent prognosis. One of the measures of how well one does in our fields is you look at certain time points, 5 years and 10 years survival, and then estimate the prognosis. So 10-year survival for type AB thymoma is in excess of 90%. It's really good. In terms of how long the disease has been there, we can't really give a precise answer to that. It's very difficult to know when exactly the tumor arose. But knowing the kinetics of growth of type AB tumors, I think it's safe to say that this tumor would have been present for months and years probably before it came to light clinically.
What does focal growth defect mean?
So maybe I can answer to this question because I think it refers to pathological report. Focal growth defect. Gross examination, it means macroscopic examination. So it's an examination with a naked eye. And probably during this examination, pathologists observed that the capsule of the tumor was disrupted. Not necessarily because of invasion of a tumor, but sometimes during even the best surgical procedure, it may happen that this capsule is disrupted focally. So in such situation, pathologists should be very cautious, and unfortunately, such region can't be assessed in details because of this disruption. That's why I guess that pathologists used this information, and it doesn't mean that it worsens prognosis. No, just pathologist said that there was a disruption of a capsule, so detailed examination of this region was impossible.
Okay, thank you. Okay, the next question, a few questions around thymic carcinoma treatment with pregnancy. Is it safe and possible for patients who diagnose with thymoma to get pregnant and to have kids? Should there be genetic testing prior to pregnancy?
So I would say if a tumor has been completely resected, it's been treated, there's no evidence of disease, and one is planning to have a family and get pregnant, I think it should be okay. In terms of whether genetic testing should be done, in general, thymic epithelial tumors are not considered an inheritable condition, with a few exceptions. There are certain syndromes. One of them, for example, is called MEN1 syndrome, where thymic carcinoids can occur with a few other types of cancers as part of a genetic syndrome. But that's really more the exception than the rule. In general, as far as we can tell at this point in time, this is not considered an inheritable condition, and therefore genetic testing is something we don't usually recommend.
Okay. Okay. Now, the next question, what is the current view on immunotherapy for those with thymic carcinoma? Is it widely recommended, or are there still concerns about it? That came up before. Any international clinical trials on immunotherapy?
So certainly immunotherapy has changed the paradigm of management, hasn't it, for so many different tumor types. And, we have been evaluating it for thymic epithelial tumors, especially at the NIH now for about 7 years. And other institutions are looking at this as well. It's really an important topic of research. I think most of us would be in agreement that it is promising in that there is certainly clinical activity against these tumors. But very, very specific and very important to notice the fact that the risk profile for thymic epithelial tumors is extremely different from what you associate with other solid tumors. And for that reason, most of us would say you should, first of all, I personally think you should consider these treatments as part of a clinical trial where the conditions, the situation is extremely closely monitored. You're doing it under very strict conditions. And certainly for thymoma, I think for thymoma, there's absolutely no doubt. We all agree that it should be done as part of a trial, and you should not do it as, off of a trial. For thymic carcinoma, I think now there's more data than there was a few years ago. So there's a bit of, I guess there are two schools of thought within our community. There are those who feel if you are able to manage, with close follow-up outside, you can get it as standard of care, although one should still be aware of risks. And others, I'm a little bit more conservative in this. I still think it should be done as part of a trial because it can have long-term side effects. There can be other immune-related issues which arise, and sometimes it can be subtle. It may escape detection until it becomes a problem down the road. So it's a very long answer, really, but the long and short of it is it can be considered preferably as part of a clinical trial.
And how long would you say you could safely be on Sudan?
So as far as sunitinib goes, sunitinib has been around for about 15 years now. The first approvals, at least in the United States, were obtained for renal cancer in, I think, the mid-2000s. So 15 years or so. What that experience has shown is that toxicity is generally not cumulative, except for thyroid, hypothyroidism. Which the risk of which can increase with time, but that's fairly easy to treat. Apart from that, there isn't, long-term toxicity that has been defined at least over a 15-year period. And having said that, how long should one use it for thymic carcinoma? I would say as long as it's working against the disease and as long as you're not having any major side effects.
Arun, you've been talking about it, and I just wanted for the patients that thymoma and thymic carcinoma are really two completely sort of different things, and stuff we talk about for one is not necessarily transferred to the other and vice versa. They're really unique to each other. So although it's all with the thymus, try not to share one experience with the other. They're really separate, and particularly the outcomes, how we treat it, and prognosis.
Thanks, Josh. Yeah, really important, and especially for these newer emerging therapies like immunotherapy, there are huge differences. You can almost consider it two different diseases, really.
Is chemotherapy recommended and metastatic thymoma accompanied by Good syndrome?
So yes, there is no reason not to use chemotherapy with Good syndrome. However, having said that, as you know, Good syndrome is a condition where you have low immunoglobulin levels that could be accompanied by low blood cell counts, which could affect one's immunity. So therefore, it could increase the risk of infections and so forth. Having said that, it's not an absolute contraindication to using chemotherapy. I mean, keep in mind, chemotherapy is immunosuppressive. So what you want to do is you want to make sure that the level of immunosuppression you already have on account of Good syndrome is not so overwhelming as to increase the risk of chemotherapy. But if there's a slight drop in immunoglobulin levels and the blood cell counts are fairly near normal, that by itself should not be an absolute indication to not use chemotherapy. So you could use it together, in other words.
Now, the second part to that question with Good syndrome, are blood cell counts the prognostic factor for overall survival of a patient with thymoma and Good syndrome?
So that's a brilliant question. So what is the prognostic implication of Good syndrome? I would say the data is relatively limited, but what there is data for, and this has been actually looked at in a big retrospective effort, performed by ITMIG a few years ago. More than 6,000 patients with paraneoplastic disease were assessed, or in other words, autoimmune conditions were assessed, and that included Good syndrome. And what was found was that the presence of autoimmunity itself was not an independent prognostic factor. However, the autoimmune conditions were associated with other features of thymomas, which were considered good prognostic factors, such as early stage of disease. So indirectly, it might be associated with a good prognosis, and that is true for autoimmune conditions in general, and that includes Good syndrome.
Okay. Any other comments on that, Dr. Sonnet?
Oh, I think that was well summarized. It is Good syndrome. Your doctors have to be aware of how to treat both syndromes, and sort of giving IVIG is not not contraindicated as when you're getting chemotherapy. They're not going to hurt each other. They're actually going to help each other to allow your immune system to be competent while you're treating, even though chemotherapy is immune compromising per se.
Okay.
If I might just add one other point, it's related to Good syndrome since we are talking about this topic. One thing to also keep in mind is, we work closely with infectious disease experts. If one is known to have Good syndrome and is prone to, getting infections. And one factor is if you suddenly start developing repeated episodes of infections, major infections like pneumonia especially, and I'm not just talking about a common cold, but pneumonias requiring IV antibiotics and things like that. What does that indicate? And one thing I would highlight is if the episodes become fairly frequent and it's not something that you have been used to previously, it may not be a bad idea to go and check your immunoglobulin levels. It's a blood test, it's simple to do. And if you find, and we have found in such instances, the immunoglobulin levels are low, and you can treat with preventative doses of immunoglobulins to decrease the risk of infections. So that's something to keep in mind in terms of the possibility of Good syndrome.
And perhaps one of the sneakiest things, or the biggest trouble with Good syndrome, are patients that are in fact not diagnosed, and they're getting these infections, and their doctors and everybody doesn't know it because it's not so common that every treating physician knows about it. So that's the real flag. It doesn't mean you have it, but it should have a very low threshold to check it. And once we know, and a treating team knows you have Good syndrome, you're pretty well controlled for the most part because we can be careful.
Okay. What are the clinical trials for stage 4 thymocarcinoma patients after ineffective chemotherapy and RET inhibitor therapy? Any recommendations?
So yes, there are clinical trials. However, ours is a small world, and the number of trials comparatively is somewhat limited. But no, there are clinical trials which are exploring various newer avenues of treatment. Some are in fact exploring chemotherapy, traditional chemotherapy with newer drugs, which make the combination more effective. Such as a combination that's being evaluated at Indiana University with taxane, a drug called Taxol. But most of the new trials are focusing on targeted therapies, on immunotherapy for sure. I guess the availability and access to trials really depends on which part of the world one is talking about. There may be differences, and I can really speak for the United States. I can tell you that there are combination immunotherapy studies, a few of them in other institutes, a couple of them at the NIH itself. We are moving beyond single agent immunotherapy and looking at combinations. There are newer drugs which are not immunotherapy, but they are what we call targeted drugs, which act on certain biological pathways, which are being evaluated. So one way to figure out what potential trials are going on where is a website called clinicaltrials.gov, G-O-V, which lists clinical trials, that, and one can search it for this particular indication.
Yes, and we actually, ITMIG we're working on a clinical trials list and updating that, and we'll share that on our website when we get that updated.
Mm-hmm.
It's one of the things we worked on. Okay, is surgical treatment recommended in a case of residual tumor thymoma after CAP, radiotherapy, and octreotide with multiple pleural metastasis? What are the options of treatment? I'm sorry if that makes sense, come through.
That I guess I'll start with that, but this is really as we talked in the beginning, this is clearly a complex patient, complex situation, and this is never a decision in a vacuum. It's always a team decision, and so can surgical therapy be applied to this sort of therapy? It is possible. It's also quite possible that surgery would not be helpful. So it's very, very particular, very personal, and that team includes the pathologist and the patient too, because these are all critical factors. They're which make it. So the answer is sometimes surgical therapy is recommended for advanced tumors with pleural metastases if we think we can get pretty much close to what's called a clean resection, even though we're pretty sure we're not curing it with surgery alone. But when we're doing an operation where we're pretty sure we're not going to completely cure it, that means the benefits are not as good as if we're pretty sure that we were going to cure it. So since the benefits are not as good, the risk has got to be lower than perhaps other operations. So if there was no risk to the operation, it makes it an easy question. Well, why don't we try it? Because there's no risk. But certainly in this situation where it sounds like maybe the whole lung has to be taken or something like that, the risks go dramatically up. So every patient and every decision about it is the risk-benefit ratio of how that's helping the patient, because we can, so it's a very tricky question. And what I would have to say is that I would just, make sure that your treatment team, which I'm almost certainly are working together in conjunction. And your treatment team can even be encouraged. Are we still doing our tumor boards, Pam?
Yes. Yes.
Our group, ITMIG, sponsors any physicians anywhere in the world to present cases to us as a team, and we can give our opinion as a group. Our opinion doesn't make it right, because we're not necessarily in there talking to the patient and getting a feel of that one-on-one, but it helps with some guidance and helps with discussion for both sides. Every time we talk about patients and meet them, we learn how to better treat every patient. Does that answer the question?
Yes, absolutely. And I was going to say that for more specific, look at a clinical case, we do have monthly tumor boards, and we can arrange with your institution, your doctors, your surgeon, and their team to discuss your case in more detail. You would need a representative, your doctor, to represent, because some of the questions are very clinical, specific to a case. But yes,
I would have to say it's not a slight on who's ever presenting. We all have wanted to present our own patients to this tumor board, because even though most of us on this call see this all the time and see a lot of patients like this, there's a lot of stuff we don't know, and we love getting input from our colleagues. So we learn every time we all share information and treat together, and we're constantly learning. And so questioning and discussing with others is not an implication of something being done wrong or doing right.
No.
Just helping us get more information and make better decisions as a group.
Mm-hmm.
And sometimes, many times, especially in cases like this, there is no one absolute right answer. It really has to be a bond between the treatment team and the patient to say, this is the avenue we're going to go down, and as long as it's reasonable. And that reasonable means no surgery and surgery, depending on the patient.
Okay. This is a little more specific to diarrhea in the course of octocide treatment, persistent for 3 months after treatment, still a side effect of treatment or a comorbidity related to thymoma.
So maybe I can take that. So if one has been on octreotide and it has, for whatever reason, been discontinued 90 days previously, and one is still having diarrhea, my suspicion would be that it is not linked to the octreotide. And one would have to, do a workup to figure out what the reason is. Can it be an autoimmune condition associated with thymoma? Absolutely, yes. Inflammatory bowel disease has been described. It's a well-known recognized entity with in patients with thymoma. You might have all heard of the term Crohn's disease or ulcerative colitis. So these are manifestations of inflammatory bowel disease, and both conditions have been described in patients with thymoma. So what should one do if there is persistent diarrhea? And by the way, remember, it may not be autoimmune. As we said, patients with thymoma are at increased risk for infection. So could it be some atypical GI infection, some sort of colitis, which is infectious rather than autoimmune? So those are the questions that one needs to think about. I think octreotide would be least likely to cause a problem in this situation. The next steps in this case, suggested next steps would be to work with a gastroenterologist, perhaps consider a colonoscopy, consider appropriate studies, stool examination and so forth, to see if it's an infectious cause, and that would probably delineate the reason behind, these repeated episodes of diarrhea.
Okay. Next couple questions are around everolimus treatment in patients with autoimmune disease. Indications, contradictions, effectiveness.
I'm sorry, in patients with autoimmune disease?
Yes, with autoimmune disease, yep.
Right.
Everolimus.
For thymomas. So in the days of chemotherapy and even targeted therapy, having an autoimmune condition, whether it was active or inactive, was not necessarily a contraindication to treatment. In fact, as Dr. Sonnet mentioned a little while ago, if the thymoma itself is the cause of the autoimmune condition, which it probably is, treating the thymoma might improve the autoimmune condition. So in other words, there are no contraindications. You should still be cautious to make sure, there isn't an exacerbation of the autoimmune condition, at least, transiently. That you're not at risk of infection, like we talked about in terms of, in association with Good syndrome. But per se, there isn't a contraindication to use of these drugs. However, the situation is radically different with immunotherapy. The one thing, if there's one take-home message here, it is that if there is an active autoimmune condition, with certain exceptions, one should not consider immunotherapy. And as we mentioned, never outside of a clinical trial. In fact, we have found that patients who have no clinical history of autoimmunity, if they have certain antibodies in blood, that itself can increase the risk of immune-related toxicity. So in the days of immunotherapy, that is relevant. But as far as standard conventional treatments, including targeted therapies go, there should not be as much of a bearing, and one could use it more often than not.
Okay, and then also, around that same, everolimus, especially with patients prior autoimmune, is it known if there are any similarities between autoimmune reactions associated with metastatic thymoma and the non-infectious described as, what is it, interstitial pneumonitis? Yes. Described as everolimus, i.e. mechanism or not.
Okay, so I think
same mechanism or not, sorry.
So just to be sure, so we are talking about pneumonitis, probably non-infectious, and what everolimus, which is one of the drugs you use for recurrent treatment, can do in that setting, correct?
Yes.
Okay, so that's an extremely important question. There are certain drugs which are more prone to causing pneumonitis than others. And in the non-immunotherapy setting, the class of drugs known as mTOR inhibitors, of which everolimus is one, has certainly quite a risk of inducing pneumonitis. And pneumonitis is nothing but inflammation of lung tissue, which can present as a persistent dry cough and worsening shortness of breath. So a few things here. The mechanisms of pneumonitis can vary. Quite often, it could be immune in nature, autoimmune in nature, but in other instances, it is, it could be infectious, and there could be other reasons. As far as thymomas go, pneumonitis can happen. And in fact, until a few years ago, there wasn't a clear association of thymoma and autoimmune pneumonitis. But with our colleagues here at the NIH, Elise Ferre and Dr. Mihalis Leonakis, who are from the Infectious Disease Institute, we did a study, I think it was 2 or 3 years ago, and published the results last year, I think, where we show that there are certain antibodies, just like there is for myasthenia gravis, it can be present in patients with thymoma, and they can actually present with pneumonitis, which many time is diagnosed as, cystic fibrosis or some other lung condition, and it turns out to be autoimmune pneumonitis. This is rare, so common things being common, you'd still look for infections, you'll still look for other reasons, but the point I'm trying to make is there is an entity known as autoimmune pneumonitis. Now, everolimus, it causes pneumonitis. It's fairly common if you take all grades of severity, and that's a challenge. You have to be very careful. But the mechanism of pneumonitis with everolimus is really what we call a hypersensitivity type reaction, and that means like an allergic reaction. It is immune. I mean, all of that is immune in nature, but not the type of autoimmunity we are talking about in relation to thymoma. And that immunity or the pneumonitis can actually be seen with other members of that class of drugs, and it's not just everolimus. So that is the distinction between the two conditions, if that helps answer the question.
Okay. How about the effectiveness of permeatexate treatment in disseminated thymoma with multiple pleural nodules?
Right. So pemetrexed is a drug which has been around for a while, and it is actually used quite often for treatment of lung cancer. It's one of the first things you use. It certainly has an established role in treatment of thymic cancers, specifically thymomas. It's actually a drug I prefer to use in the second line setting. So, you've been treated up front and the disease comes back, like Pam just mentioned, multiple pleural nodules. If you don't think it's surgically resectable and you basically need systemic therapy, which would be the case in most cases, I actually favor pemetrexed if there's no clinical trial and so forth, because it's a well-tolerated drug. I personally had patients on it for years on end, with very good response, and the tolerability, they tolerate it very well. That's the general experience. In terms of how long the effect lasts, the duration of response can, as I said, it's measurable in years. And even the average in a study done at Indiana University a few years ago for patients with thymoma is approximately 1 year, 12 months, and that's just the average. So a lot of patients do much better than that. And I said, I've had patients on it for years. For thymic carcinoma, it's a whole different story because this drug is not active, really active in patients with thymic carcinoma. In that study, the duration of response for thymic carcinoma was in the range of about 2 or 3 months. And the response rate was actually quite low. So the bottom line is I do use it quite early, quite often for management of thymoma, but not thymic carcinoma.
Okay. And now starting to get to some questions coming in. This is, let's see, someone has been diagnosed with metastatic tumor squamous cell carcinoma last week. It's metastasized in the liver. Has not had treatment yet. What recommendations do you have about initial treatment?
So I'm sorry to hear that. So we are talking about squamous cell carcinoma, what we would call stage 4, because there is liver involvement. Most of these cases are not surgically resectable, and Dr. Sonnet can expand on that. If there's one solitary liver metastasis and otherwise the disease is restricted to the chest and potentially operable, it would be a little unorthodox, but could you think about removing the one liver metastasis and then operating on the main tumor? It's not considered standard care by any means, but if one were to think out of the box, that's a thought one can think about. But in general, this indicates the fact that the disease is metastasized, unfortunately. So what you need is systemic therapy. And as I mentioned earlier, the systemic regimens for this disease, which are considered acceptable, are essentially multimodality chemotherapy, which would include what we call platinum drug, along with a couple of others. one of the most common regimens we use here, at least in the United States, is the CAP regimen, which many of you will be familiar with. It's a 3-drug combination. Carboplatin with Taxol can also be used. There's nothing to say one is better than the other, at least in my opinion. Those are some things you can start off with in the frontline setting. I always encourage one to look for clinical trials if there are any for frontline disease. I would say at least the trials that I know of require prior treatment with platinum, but there may be studies or which might come around for this setting. So short answer: systemic therapy, platinum-based combinations as the frontline treatment.
And Arun, can you just in a very broad sense let patients know that if somebody shows up with metastatic or non-resectable thymoma versus thymic carcinoma, what your initial treatment options are and how they're different?
Sure. So again, the frontline treatment options don't. I would say there isn't as much of an impact in terms of systemic therapy. Based on the histology, I still pretty much recommend cisplatinum with doxorubicin and cyclophosphamide, which is the PAC regimen. The response rates are higher in patients with thymoma than they are in patients with thymic carcinoma, but I don't differentiate necessarily based on histology. However, one exception is there are tumors, thymic carcinomas, which have what are known as neuroendocrine features, or neuroendocrine carcinoma of thymus and so forth. So in that particular setting, and this has been shown for other cancers as well, there is a drug called etoposide or VP16 that can be used. It's used fairly often for these neuroendocrine cancers. So there is a regimen, another long-standing regimen for thymic cancers, which involves cisplatinum with etoposide. So I preferentially try and use that or recommend that in patients who have any type of neuroendocrine cancer of the thymus. But in other instances, whether it's a thymoma or a thymic carcinoma, I generally tend to recommend CAP or PAC as the frontline treatment.
And would it be safe to say that some patients that have neuroendocrine, they might have been told they have small cell of the thymus?
Absolutely. So neuroendocrine cancers in general lie along the spectrum from carcinoids, which are relatively less aggressive, but they can still cause symptoms, to small cell cancers, which are extremely aggressive and fast growing, and they can occur in any organ. So small cell lung cancer is your prototype, a very, very, aggressive disease. But rarely small cell cancers have been diagnosed of the thymus as well. Now, whether they are equally aggressive as small cell lung is a matter of debate. They are very responsive to chemotherapy. So actually, ironically, if you start chemo, you would expect a very rapid and very quick response. But the problem is they tend to come back. So that is the issues to bear in mind. It's an extremely rare situation as far as we are concerned. But as Dr. Sonnet mentioned, histologically, there are features which may look similar to atypical carcinoids or carcinoids. There is more to it than just looking at the cells. There's something called the proliferation index and so forth. And maybe Margaret can expand on this, but that's the reason sometimes it can be mistaken. Atypical carcinoids can be mistaken for carcinoma, small cell carcinomas of the thymus.
Yes, absolutely agreed. Especially in small biopsy material, it is sometimes very difficult to differentiate between carcinoid and neuroendocrine carcinoma. It refers to both thymic neoplasm or lung carcinoma. But we have in pathology some tools, immunohistochemistry, that help us, and we can, in most cases, we can differentiate between these entities, carcinoids and neuroendocrine carcinomas. It's much more difficult for us to differentiate between large cell neuroendocrine carcinoma and small cell neuroendocrine carcinoma, both in the thymus or in the lung. Sometimes for us it is almost impossible to differentiate, to be sure that we diagnose correctly. So we do our best, but in these entities, it's sometimes it's very difficult to make a decision.
Thanks. And Josh, if I might just ask you, from the surgical literature, if you had what would have been basically a stage 1 thymic cancer, but for the fact that there's one solitary liver metastasis, what is the literature in the surgical end of things? You know, is with oligometastatic disease, like the case for non-small cell lung cancer, is there even a role for surgery, metastasectomy as well as primary surgery for the primary tumor?
I think that's a good question. There's clearly not enough patients with that scenario to have an absolute answer, but from the field of what we'll call oligometastatic, in other words, lung cancer and other cancers that are doing this now, we do know that there are a subset of patients with a primary cancer and for whatever reason, one isolated metastasis or two isolated metastases, that if we can approach both of those in a curative manner, we can still try to cure that patient. So the answer is yes, there may be a role. In general, a lot of times we will start that patient more on a non-surgical approach with some type of treatment. And then when it's clear that they're doing well, and those are the only 2 sites after some site of treatment, in other words, it hasn't popped up in other places, then we would aggressively go after the primary site and the liver, adrenal, or radiation of a single bone. So the answer is yes, there may be a role for attacking different sites. And we now know in lung cancer, and lung cancer is completely different though, even patients who are years with unresectable disease and metastatic disease, that going back and treating the primary, if it's active, improves their overall survival and lifespan. So the answer is there may be a role. And again, akin to the first surgical question is, how much of a big deal is it to take out that primary? So if we know we can take out that primary and maybe offer some health at a low risk to the patient, then it may be considered. The higher that risk to the patient is, if that patient has other comorbidities or it's such a giant operation, then the less benefit it is and the more we're going to have trepidation to approach that. So everybody's a bit unique, but there definitely can be a role in aggressively treating, we'll say for curative intent, all the spots.
Thank you. Yeah, and that's an approach we as medical oncologists and surgeons jointly, you know, we follow this. The fear is there may be metastatic disease, there may be cells in the circulation that you simply cannot detect with a scan. So although it may look like you have one liver or one adrenal metastasis, you may have other things floating around. And if you go and operate on what you can see, you may be back to square one, you know, if truly there are things in the circulation. So as Dr. Sonnet mentioned, we give it the test of time, start systemic therapy. You finish, you know, 4 or 6 cycles over a few months. And if at that point in time, you still have one little solitary area, as he mentioned, it's very reasonable to go after it, give it the benefit of the doubt, you know, assuming that that's all there is. So that approach certainly has a track record in other cancers like lung cancer and colon cancer, not so much in thymic cancers because of the rarity of the disease, but the same principles might apply.
Now, what would you say in talking about thymoma and thymocarcinoma? What is the difference with between them and with reoccurrence?
So that basically reflects the prognostic value of histology, and in the experience from ITMIG itself that I referred to at the outset, where prognostic factors were looked at. It was I think an ITMIG position paper from 2011. Histology, thymoma, thymocarcinoma, subtypes of thymoma were a fairly strong predictor of the risk of recurrence and overall outcome. But that is in conjunction with other factors as well. So it does not negate the importance of getting a complete surgical resection or the stage of the disease. But yes, it is an independent factor which has prognostic implications. And as you know, thymic carcinomas are at higher risk for recurrence after the same degree of aggressive treatment. So we are very, very, as I mentioned, aggressive about it. More often we use radiation after completion of surgery for thymic carcinoma than we do for thymoma. And that again is because of the higher risk of recurrence.
in particular in the lymph nodes and further away rather than locally, which is more thymoma.
Correct.
Are we any closer to finding a cure for this disease?
Yeah, I wish I could say, it's on the horizon, but the fact of the matter is it's a challenging disease. We certainly are in a much better position we are today than we were even a few years ago in terms of understanding the disease, the molecular underpinnings of it, the association with the immune system, the effect of various genes. But there's still a lot that needs to be figured out. Can I foresee a cure next year? To be very candid, the answer would be no. But am I in a much better position to, figure out the implications of a certain of the disease on a certain individual, and look more in a more sophisticated way at the genetics and other features? The answer is yes. It's a journey, like it is for other cancers as well. We are in a much better position than we were, and the pace of research, I have to say, is remarkable. For a disease as rare as this, especially, I think all my colleagues in ITMIG would agree with that, and you've all seen it as well. There are rapid strides being made, so I would certainly keep that in mind. It's a situation filled with hope. And hopefully we are marching towards, definitively treating these diseases.
Agreed. Significant progress has been made, and in almost no disease is it magically go from a single bullet cure. It's really everybody ganging up with different multimodalities and a mix between cure and control and learning to live with the disease for some patients.
Yes. Okay, well, there's a few questions that we weren't able to get to, but we are coming up on the 11 o'clock hour to US Eastern time. So I'm going to, I think we should talk about moving forward. I can collect the rest of the questions on the chat, and I can compile with the panel, and we can get back or post some answers to the questions that we were not able to get to. Thank you, everybody, for all of your time, and definitely to the panel, to Dr. Rajan, Dr. Sonnet, everybody who's joined in. Are there any other comments from the panel that you'd like to say to close out?
I feel bad that there was some questions, like I know there was a radiology question Edith could have handled quite handily on the chat. So maybe you can follow up.
Let's see. Okay, yeah, I was going to say, let's see. Down there, yeah, there were a few. And we could compile, but we had many great questions. Hopefully this was helpful to everybody. The organization is going to be holding a series of webinars coming up through the fall, through the next couple months. I can share that on Facebook. If anybody is interested in joining those and presentations, I can share that information.
Okay.
Please feel free to reach out to me on Facebook or via email if you have any more questions about the organization.
I would like to thank the patients for participating. I think this has been fantastic.
Yeah.
It makes me think we should do this more regularly if the patients think it was just as helpful. Presumably,
I agree.
A mix of different patients and everything, and this is grow. So, Margarita, I would idea, I believe so. Margaret, so thank you.
I would echo those thoughts. I really think there were very many thought-provoking questions, and this is a situation where we all grow together, patients and physicians, researchers, we make progress jointly. So thank you all, for bringing up these important questions, and stay hopeful. There is a lot of progress being made. There are a lot of options being developed. I think the future is filled with promise. So thank you.
Okay. Thank you very much. And we did have one of these WebExes it was about 2 years ago with patients. I think based on this one as well, I think we should continue to do this maybe a few times a year. And we'd love to hear your feedback from the patients. Please feel free to reach out to me. And again, this has been recorded. So we'll be putting we'll put this on Facebook as well as our website.
And Pam, thank you for putting this together. It's been very helpful.
Great. Thank you.
As always, thank you, Pam.
Okay, sure. Okay, I'm going to copy these questions and share them with the panel. We can go from there.
Be well, everybody. Stay safe, please.
Thank you.
Take care.
Thank you.